Hey there, curious minds, and welcome back to the Deep Dive.
Great to be here.
Today we're tackling something, well, pretty fundamental, but also really complex in mental health. Trauma, stress, and loss.
Absolutely. Core concepts.
We're basically ripping open a chapter from Psychopathology and Mental Distress to give you, our listeners, a clear, accurate, and hopefully really engaging understanding. Our mission is to cut through the noise, get those precise clinical definitions down, explore how diagnoses happen, and honestly trace the kind of wild journey our understanding has taken over time.
And across cultures, too. It's not monolithic.
Exactly. Get ready to connect some dots, because we're about to make sense of how we experience and react to life's toughest curveballs.
It's critical stuff for anyone studying mental health. And, so many terms we just toss around daily, like trauma or stress, they have very specific clinical meanings. Understanding those nuances is foundational. And seeing how our thinking has evolved, that leads to all these different diagnostic approaches, different therapies, each with strengths and, ongoing debates.
Okay, let's unpack this then. Before we dive into the clinical stuff, we probably need to clarify some basics, terms that get used pretty loosely, right?
Definitely.
Like trauma, stress, bereavement, grief, and dissociation. What do clinicians actually mean?
Precisely. Let's start with trauma. Clinically, it's way more specific than just, say, a tough exam or a bad day.
Oh.
The DSM, that's the main diagnostic manual in the U.S., defines it as exposure to actual or threatened death, serious injury, or sexual violence.
Wow, okay. Pretty serious stuff.
Exactly. The ICD-11, the international system, adds things like natural disasters, combat, torture, witnessing violent deaths. So it helps us separate these really life-altering events from other upsetting experiences. Think about the case example, Joe. A 30-year-old man trapped in an earthquake. He survived, but that event clearly meets the clinical definition. It immediately puts his experience in a different category than just, having a stressful week.
That really clarifies trauma. But stress, everyone feels stressed, right?
Right.
How do we pin that down clinically?
Yeah, it's broad. We often think of it as just feeling overwhelmed, but Hans Lee's General Adaptation Syndrome, or GAS, gives us a useful framework.
JS.
Yeah. Think of it in 3 stages. First, the alarm reaction, that's your initial fight or flight. Body goes on high alert. Then, if the stressor sticks around, you enter the resistance phase. Your body tries to adapt, cope, keep functioning.
Okay.
But if it goes on too long or it's just too much, you hit exhaustion, resources depleted. That's where you see long-term health problems.
So it's a whole physiological process.
It is. And importantly, stress isn't always negative. Big positive life changes, getting married, a new job, they trigger this stress response too. It's about adapting to any major demand.
That's a great point. Okay, then bereavement and grief. They seem so tightly linked.
They are, but distinct. Bereavement is the situation. It's the objective fact of having lost someone significant through death. You are bereaved.
Okay, the state of being.
Right. And grief is the response. It's the emotional, physical, cognitive, behavioral reaction to that bereavement.
Got it.
And grief is incredibly common. Some studies called it a public health issue. Even before the pandemic, significantly increased rates of loss.
Wow.
Now, we often hear about Kubler-Ross's 5 stages, right? Denial, anger, bargaining.
Yeah, everyone knows those.
Well, here's the thing. That model gets a lot of criticism now. It's seen as too simplistic, it doesn't account for cultural differences, and honestly, the research support just isn't that strong.
Really? That's surprising.
Yeah. Many now argue grief isn't some neat sequence you pass through and finish. It's more like a lifelong process. It evolves, changes shape, but doesn't necessarily have an end point.
That feels more realistic, actually, less prescriptive.
Okay.
Last one, dissociation. This one sounds kind of eerie.
It can be, and it's often hard for people to describe. It's essentially a detachment from experience. Like compartmentalizing emotions, identity, reality itself.
How does that show up?
2 common forms are derealization, where the external world feels strange, unreal, foggy, maybe colors seem dull or time feels slowed down.
Like the example of Marigold, who felt food didn't taste right after her husband died.
Exactly. That feeling that the world itself is altered. The other is depersonalization, where you feel unreal, detached from your own body, thoughts, or feelings, like you're watching yourself from the outside.
Joe's feeling during the earthquake, outside his own body, watching it happen.
Perfect example of depersonalization. And sometimes we see amnesia, memory gaps, especially around highly emotional events. It's a way the mind tries to cope with overwhelming input.
Okay, those definitions are super helpful. So now we have the terms. How do the big diagnostic systems DSM and ICD actually classify these experiences? What are the main disorders?
Right. Both the DSM-5-TR and the ICD-11 have chapters dedicated to trauma and stressor-related disorders.
Makes sense.
For PTSD, post-traumatic stress disorder, both systems require exposure to a traumatic event as we defined it. But here's a major difference. ICD-11 actually splits it.
Oh, how so?
ICD-11 has PTSD, which focuses on core symptoms like re-experiencing avoidance and feeling under threat. But it also has complex PTSD.
Complex PTSD, what does that add?
It adds difficulties with managing emotions, really negative beliefs about yourself, and persistent problems in relationships. Stuff that often comes from prolonged or repeated trauma, like childhood abuse.
So back to Joe.
Yeah.
His nightmares and jumpiness fit PTSD. But if he also had ongoing relationship issues with Carol, maybe stemming from the trauma's impact, that might point towards complex PTSD under the ICD system.
Exactly. It allows for that extra layer of complexity. And here's something fascinating, the vulnerability paradox.
Paradox.
Yeah, studies show PTSD rates are actually higher in high-income countries.
That seems backwards. Wouldn't there be more trauma exposure in lower income or conflict zones?
You think so? But it might be about expectations. Maybe in safer societies, trauma feels more disruptive to the expected norm. Or perhaps there's less stigma around reporting in some places. It shows how culture shapes not just risk, but how we frame and report distress.
That's really interesting. What about the immediate aftermath? Acute stress.
Good question. Here again, DSM and ICD differ. DSM has acute stress disorder, PTSD-like symptoms lasting 3 days to a month. It's a diagnosis.
Okay.
ICD, however, calls it an acute stress reaction. They view it more as a normal, expected response, not necessarily a disorder.
Ah, the pathologizing debate again.
Yeah, exactly. Are we labeling normal human responses? Then there's adjustment disorder. This is for reactions to stressors that don't meet the trauma definition, like divorce, job loss, but still cause significant distress or impair functioning.
That sounds like it could cover a lot.
It does. It's sometimes called a wastebasket diagnosis because the criteria are broad. But pragmatically, especially in the U.S., it allows people to get insurance coverage for therapy when they might not meet criteria for something else.
So a practical function, but maybe conceptually fuzzy.
Right. It raises that question. Are we prioritizing access to care, or are we medicalizing everyday struggles? It's a tension.
And I heard both systems added something new for grief. Prolonged grief disorder.
Yes, that's a big one. Both DSM-5-TR and ICD-11 introduced prolonged grief disorder. This is for grief that remains intense, persistent, and disabling well beyond typical timeframes. DSM says 12 months, ICD says 6 months, with cultural caveats.
Like Marigold, 3 years after her husband's death, still deeply debilitated by grief.
Exactly. Her experience might fit this diagnosis. But it's hugely controversial.
Well, not controversial.
Supporters argue it validates intense suffering, helps people get help, and spurs research. Critics, though, argue strongly that we're medicalizing a natural, albeit incredibly painful human process. Leet Granick's lived experience perspective in the text is powerful here, arguing grief is lifelong, not something with an expiration date.
I see the conflict. Validating suffering versus potentially pathologizing a core human experience.
That's the heart of it. And it ties into those alternative perspectives, too. You have things like the PDM-2 focusing on the relational aspects, High Top looking at symptoms on spectrums, and PTMF avoiding trauma altogether, preferring adversity to sidestep medicalization.
Lots of different lenses. And what about kids?
Right. There are specific childhood diagnoses tied to early adversity, like reactive attachment disorder and disinhibited social engagement disorder, related to severe neglect impacting attachment patterns.
Okay, so clearly our understanding isn't set in stone. It sounds like it's evolved a lot. What's the history here? How did we even get to the idea of PTSD?
Oh, the history is fascinating. Descriptions of symptoms we'd now call PTSD go way back. Samuel Pepys, after the Great Fire of London in 1666, wrote about nightmares and fear. During the U.S. Civil War, they called it soldier's heart.
But often dismissed, right, as weakness.
Often, yes. Or malingering faking it. In the 1880s, Hermann Oppenheim coined traumatic neurosis, but he thought it had physical, organic causes in the nervous system. That contrasted with psychological views, like Freud's, which focused on repressed memories and psychic conflict.
So that biological versus psychological debate started early.
It really did. Then came WWI, with terms like war neurasthenia and the famous shell shock. Again, lots of debate. Was it physical concussion from explosions or psychological breakdown?
Still searching for explanations.
Exactly. Then after WWI, a key figure was Abram Cardinal. He described traumatic neurosis with symptoms incredibly close to modern PTSD, exaggerated startle, irritability, nightmares, being preoccupied with the trauma. He really nailed the core features.
So why didn't PTSD become a diagnosis then?
Well, his work was influential but didn't immediately translate into official diagnosis. Terms kept changing: combat fatigue, battle stress. And here's a real shocker. Between 1968 and 1980, the DSM, the main psychiatric manual, had no specific diagnosis for trauma reactions.
Wow, really? A whole gap.
Yeah. PTSD itself only appeared in DSM-III in 1980, and a huge driver for that was lobbying by Vietnam War veterans and advocacy groups who needed recognition for their suffering.
So it came from advocacy demanding recognition.
Largely, yes. And once established, the definition quickly broadened beyond combat to include survivors of rape, accidents, natural disasters, and so on.
So PTSD is actually pretty recent, diagnostically speaking, and it's still evolving.
Absolutely. The ICD-11 changes, adding complex PTSD, show it's still a work in progress. It really highlights that diagnoses aren't just objective labels. They reflect the science, culture, and even politics of their time. Some historians even call PTSD a culture-bound syndrome in some ways.
Okay, so we've got definitions, diagnoses, history. Let's pivot to the biology. What's actually happening in the brain and body during trauma, stress, loss?
Great question. There's a lot going on. On the level of brain chemistry, neurotransmitters like serotonin and norepinephrine are definitely involved. That's why SSRIs and SNRIs are often used for PTSD.
Do they work well?
The evidence is a bit mixed on how much they help compared to therapy. They're often considered second line after trauma-focused psychotherapy. Other meds like prazosin can help with nightmares, but things like benzodiazepines, generally not recommended long-term for PTSD.
Like Joe, who took Paxil and prazosin. He felt it helped some, but therapy helped more.
Exactly. It shows medication can have a role, but it's often part of a bigger picture. Then there's brain structure and function.
What do we see there?
We often see reduced volume in the hippocampus, which is key for memory consolidation. And often in overactive amygdala, the brain's fear center, coupled with an underactive medial prefrontal cortex, which usually helps regulate emotions and decision-making.
But is that the cause of PTSD or the result?
That's the million-dollar question. It's hard to untangle cause and effect. We also see dysregulation in the autonomic axis. The main stress hormone system can also go haywire.
Is there research on intervening biologically right after trauma?
Yes, some interesting work on using hydrocortisone immediately post-trauma. But the catch is it needs to be given within about 6 hours, so a very narrow window.
Tough logistically. What about genetics? Does that play a role?
It does. While trauma is obviously environmental, genetics contribute significantly to vulnerability, maybe 30–40% heritability. Specific genes, like variations in the serotonin transporter gene, 5-HTT, are being studied, but it's complex gene-environment interactions.
Not just one PTSD gene.
Definitely not. And from an evolutionary perspective, these responses, fight or flight, stress, even grief, likely evolved because they were adaptive for survival or social bonding. PTSD might be seen as these systems malfunctioning or getting stuck on.
So an adaptive response gone wrong.
Potentially. Even grief, while painful, might reflect our evolved capacity for strong attachments, which helps group survival. Lastly, there's the immune system. Chronic stress, trauma, loss, they're linked to inflammation, which increases risk for physical illness.
So it really impacts the whole body. But
Yeah.
You mentioned limitations.
Absolutely. A lot of the biological evidence is correlational, sometimes contradictory. And the RDOC perspective critiques a lot of this research for starting with potentially flawed DSM-III categories instead of basic neurobiology. Are we just finding markers for existing labels or understanding underlying mechanisms?
A fundamental challenge. Okay, let's shift from biology to psychology. What are the main mind-based ways we help people cope?
Lots of approaches here. Psychodynamic therapies, drawing from Freud and others, look at how personality factors and unconscious conflicts play a role. The idea is to work through past trauma within the therapeutic relationship, making the unconscious conscious.
How might that work for someone like Marigold with her grief?
A psychodynamic therapist might help her explore memories of her husband, gently address avoidance patterns, and help her navigate the complex emotions of loss, the working through process. These therapies show effectiveness, but often have less large-scale research backing than CBT.
Right, which brings us to cognitive behavioral therapies, CBT. They seem central in trauma treatment.
They absolutely are, especially exposure therapies. These are considered first line for PTSD.
How does exposure work? It sounds scary.
It involves carefully and gradually confronting trauma-related memories, feelings, or situations in a safe, controlled way. It could be imaginal exposure, vividly recounting the memory, or in vivo exposure, gradually facing real-life reminders.
Like Joe visiting the earthquake site.
Exactly. The goal is habituation, learning that the memory or reminder itself isn't dangerous, and the anxiety decreases over time. Then there's cognitive processing therapy, CPT.
What's the focus there?
CPT targets the thoughts and beliefs that get distorted by trauma. Things like self-blame, it was my fault, or beliefs about safety, the world is totally dangerous, or trust. It helps people challenge and restructure those maladaptive thoughts.
So helping Joe challenge his fear of another earthquake.
Precisely. Maybe examining the actual probability, looking at how the fear impacts his life now, and developing more balanced thoughts. Writing a detailed narrative of the trauma can also be part of CPT to help process it.
Makes sense. What other CBT approaches are there?
There's cognitive therapy for PTSD, behavioral activation to combat withdrawal, trauma-focused CBT, TFCBT, specifically for kids, often involving parents, and stress inoculation training, SIT, which teaches coping skills like relaxation and mindfulness.
Mindfulness comes up a lot now.
Yes, approaches like MBCT and ACT use mindfulness to help people observe difficult thoughts and feelings without getting swept away, fostering acceptance instead of avoidance, though caution is needed for severe PTSD initially.
Okay. Then there's EMDR, eye movement desensitization, and reprocessing. That one always sounds unique.
It is. Clients recall traumatic memories while doing bilateral stimulation, like following the therapist's fingers with their eyes. It's effective, research supports it, but why it works is debated. Some say it's the eye movements, others say it's basically a form of exposure.
The Oklahoma City bombing example was powerful, the mother shifting from their traumatic image to positive memories.
Yes, it highlights its potential for integrating difficult experiences. Then we have humanistic perspectives.
Like Carl Rogers.
Exactly. Person-centered therapy emphasizes empathy, genuineness, unconditional positive regard the relationship is the healing factor. Constructivist approaches focus on meaning reconstruction, helping survivors rebuild their worldview after it's been shattered by trauma.
And that ties into post-traumatic growth, right?
Yeah.
PTG.
Yes. The idea that people can experience positive changes because of struggling with crisis, deeper relationships, new appreciation for life, increased wisdom, like Joe feeling closer to loved ones after the earthquake.
It's a hopeful idea.
It is, but we need to be careful. Research needs to ensure it's genuine growth, not just saying you've grown. And crucially, growth and suffering often coexist. It doesn't negate the pain.
So a whole toolkit of therapies. Is
Yeah.
there one best way? And have we learned from mistakes?
Well, trauma-focused CBT, exposure, and EMDR generally have the strongest research backing for PTSD, but there's the ongoing dodo bird verdict debate. Maybe all good faith therapies work roughly equally well due to common factors like the therapeutic relationship. And yes, we learned a big lesson from critical incident stress debriefing, CISD.
What was that?
It was a common practice to have people talk through trauma immediately after an event, often in a group. But research showed it wasn't helpful and could even be harmful for some, maybe forcing processing too soon.
Ouch. So what's the alternative now?
Psychological first aid, PFA. It's much less intrusive. Focuses on basic needs, safety, calming, connection, practical help, fostering hope. It respects natural resilience rather than assuming everyone needs immediate debriefing. That shift is really important.
That makes a lot of sense. Okay, let's zoom out. How does the wider social and cultural world shape these experiences? Gender, race, support systems?
Hugely important factors. Take gender. Women are diagnosed with PTSD about 2-3 times more often than men.
Why is that? Lower exposure overall, you said?
Lower rates of some traumas, yes, but women experience higher rates of others, particularly interpersonal traumas like sexual assault, which often occur repeatedly and carry immense stigma. That context matters.
Okay. And race and socioeconomic status?
Strong links there, too. Poverty, belonging to a minority group, these are associated with higher PTSD rates, which leads to a critical question the chapter raises. Can racism itself cause post-traumatic stress?
That's a powerful question.
The vignette about the Hispanic and African-American couple being denied housing and the wife's resulting stress symptoms that illustrates how cumulative experiences of discrimination, microaggressions, systemic barriers can act as ongoing traumatic stressors.
So it's not just single events.
Exactly. Social justice advocates argue that things like racial profiling, police brutality, institutional discrimination have profound psychological impacts that need recognition, potentially even within diagnostic criteria. This requires cultural adaptations of treatments, too, making sure therapies fit diverse experiences.
And social support. Seems obvious it helps.
It's crucial. Lack of social support predicts worse outcomes. And PTSD itself can damage relationships, eroding that support, creating a negative cycle. We also see huge cross-cultural differences in things like bereavement rituals and grief expression. What looks like complicated grief in one culture might be totally normal in another.
So clinicians need cultural humility.
Absolutely, to avoid pathologizing difference. And finally, stigma. PTSD diagnosis came from veterans seeking recognition, but diagnoses still carry stigma. Many vets prefer post-traumatic stress injury, PTSI, to reduce that sense of being disordered.
And Marigold felt shame about the prolonged grief label.
Yes, even while acknowledging the concept helped her feel less alone, the potential label increased her reluctance to seek help because of perceived stigma. It shows the double-edged sword of diagnosis.
So these are definitely not just individual issues. They're embedded in society.
Precisely. Individual biology and psychology matter, but the sociocultural context often triggers, shapes, and maintains these experiences.
Which makes sense, then, that therapy might evolve more than just one person. What about group, couple, and family approaches?
Absolutely vital. These approaches see trauma and loss impacting the whole system. Group therapy for PTSD is very common. Groups can be supportive, educational, psychodynamic, or CBT-focused.
So Joe joining a group could help him feel less isolated.
Exactly.
Yeah.
Share experiences, get validation, learn coping skills from peers. The research evidence is still growing, especially for non-CBT groups, but they're widely used. Then there's couples and family therapy.
How does that work for trauma?
Well, you have things like cognitive behavioral conjoint therapy, CBCT, for couples where one has PTSD. It focuses on communication, managing conflict that arises from PTSD symptoms, overcoming avoidance together, finding shared meaning.
Working as a team.
Right. And emotionally focused couples therapy, EFCT, uses attachment theory to help couples connect emotionally and support each other through the trauma's aftermath. There are also family-focused grief therapies, and even emerging research looking at using substances like MDMA alongside couples therapy for trauma.
Wow, that's cutting edge.
Definitely an area to watch.
Okay, what a comprehensive journey we've taken. We've defined those core terms: trauma, stress, grief, dissociation. We've navigated the complex, sometimes controversial world of diagnosis PTSD, complex PTSD, prolonged grief. We've traced the history, explored the biology, examined a huge range of psychological therapies from psychodynamic to CBT to humanistic approaches, and considered the vital sociocultural context.
And seen how cases like Joe and Marigold really bring these concepts alive.
Absolutely. You, our listeners, should now have a really solid foundation for understanding the profound impacts of these experiences.
It really is a journey from the brain cells right up to societal structures, and it shows how mental health science is constantly evolving, questioning itself, trying to get better. But here's something to leave you thinking about. Researchers are seriously exploring ways to potentially erase traumatic memories, using drugs, maybe even targeted sounds during sleep. If we could actually develop the ability to selectively eliminate or alter distressing memories, should we?
Wow, that's a heavy question.
What are the ethics? Would it prevent post-traumatic growth? Or just relieve unbearable suffering? When, if ever, would it be right to erase the memory of profound grief or a life-altering trauma? Something to really mull over.
Definitely powerful food for thought. It touches on what it means to remember, to heal, to be human. Thank you for joining us on this deep dive. We hope this has sparked new insights and armed you with valuable knowledge for your studies. From the whole deep dive team, we really appreciate you tuning in. And that wraps up our deep dive into trauma, stress, and loss today.
We covered a lot, from the core definitions using cases like Joe and Marigold
to the complexities of DSM and ICD diagnoses, the controversies around things like prolonged grief disorder.
Tracing that fascinating history from soldier's heart to PTSD and getting into the biology, brain chemistry, genetics, the immune system.
Then exploring that rich landscape of psychological help, psychodynamic ideas, all those CBT techniques like exposure and CPT, EMDR's unique approach, and the focus on meaning and growth.
And finally, putting it all in context: gender, race, culture, social support, stigma, and the importance of group and family approaches.
It's a field full of discovery, debate, and deep human significance. Thank you for making this deep dive with us. We hope you feel more informed and equipped to think critically about these vital topics.
We hope this serves you well in your academic journey. From the entire Last Minute Lecture team, thank you for listening.